And people are a lot more understanding of the importance of things like clinical research. If it wasn't for those wonderful individuals that came forward to be part of the clinical trials for our vaccines, we would not be in the position that we're in at the moment and able to have this conference where over 100 of us are sitting here and able to enjoy today's and tonight's proceedings. It just wouldn't have happened if it wasn't for that game changer of the vaccine.
Welcome everybody, both our guests in the audience tonight and our guests that are joining live. I believe we have nearly 200 of you joining by webinar to Innovating Healthcare Scotland. We're honoured tonight to have panel leaders from Scottish Government and the NHS, all of whom have got a great reputation, not only for having vision and a mission sense of purpose, but also people who get things done. They're each going to talk about the challenges as they see around innovation, but also how some of those challenges can be turned into solutions to improve the health and wealth of the Scottish nation and its people. So first of all, may I introduce a man who needs very little introduction, following his exemplary leadership with the rollout of the COVID vaccination programme across Scotland, Humza Yousaf MSP, Cabinet Secretary of Health and Social Care, Member of the Scottish Parliament for Glasgow Pollock since 2016, having previously represented Glasgow region from 2011 to 2016. Professor Dominiczak, a leading cardiovascular scientist and clinical academic, who was appointed as the new Chief Scientist for Health for the Scottish Government. She only took up the post on July the 1st, 2022, and people are saying she's already making a huge difference. And her mission is to ensure that Scotland remains an internationally recognised home of impactful health research, development and innovation. During the pandemic, Professor Dominiczak successfully led the establishment of the Lighthouse Laboratory in Glasgow and was awarded a DBE for services to cardiovascular medical science in 2016. One of my favourite descriptions of Dominiczak is that she is a bona fide trailblazer in cardiovascular science and medicine. We were to have Professor Jan Gardner tonight, the Chief Executive of the NHS Golden Jubilee, where the Centre for Sustainable Delivery is based. Unfortunately, her mother was taken very ill today, but thankfully, Tom Steele has stepped in very manfully, if I may say, to take her place. What's qualifying Tom to be here tonight is that he was appointed as Chair of the Scottish Ambulance Service Board on the 1st of June 2018. But in particular, from 2014, he served as a non-executive board member of the Audit Committee at NHS Lanarkshire, and currently he's co-chairing the National Health and Social Care Innovation Design Authority and chairing the NHS Scotland Volunteering Board. Before that, he spent a career in management consultancy with KPMG and then in the IT industry, where for 20 years he held various senior executive positions with Fujitsu. Tom only stood in at 2:30 this afternoon, so we're really, really grateful for him doing that. I'd like to introduce Sue Webber, who's the Conservative member of the Scottish Parliament for Lothian since May 2021. She sits on 9 cross-party groups, including health cross-party groups on cancer, drug and alcohol misuse, inflammatory bowel disease, and on the Scottish Parliament cross-party group for life sciences. So welcome, Sue. And finally, the English voice on the panel tonight, Chris Carrigan. Chris is here in his capacity as expert advisor to an organisation, a patient organisation called Use My Data, which is the only independent movement in the UK focused on patient data. Chris is an experienced and nationally recognised senior leader with a background in health data, informatics, cancer and patient advocacy, who is a true advocate for a focus on ensuring patient voice is heard. He was appointed in February 2018 as a Rutherford Fellow to work in the area of patient and data for Health Data Research UK, based at the University of Leeds. Chris is also the HDR UK Cancer Hub DataCan Chief Operating Officer and Patient and Public Involvement Lead. So I'd like to invite the audience today to welcome our panellists in the traditional way. So many of you are going to be wondering who on earth this organisation with an unpronounceable name, IQVIA, is all about and why we're hosting the event tonight. And we hope that this is going to be one of many events going forward in Scotland. IQVIA is a global human data science and clinical research organisation who delivered most of the global COVID vaccine treatment trials. And in the UK, we are a lead partner delivering the ONS COVID infection survey, which informed the R rate, delivering 9 million swabs and bloods across 4 million households, including in Scotland, from April 2020. And that particular survey is held up as a global exemplar across the world and the envy of the world for innovation as a pandemic public health surveillance programme. I'd also like to talk about our colleagues from Q Squared Solutions. Q Squared Solutions is a wholly owned subsidiary of IQVIA, and they undertake all the testing of biosamples from clinical trials from countries as far-flung as Indonesia, Malawi, other countries in Africa, and those samples are flown into Edinburgh Airport every morning, and the results of their analysis are turned around in 24 hours and got back to clinical trial sites all around the world within 24 hours. So that's who we are. Now on to the event. So tonight's event is the third in a series of question time type events. I'm not Fiona Bruce, that IQVIA has commissioned Chamber UK to deliver. And they're very much about getting perspectives from across the country on how life sciences and healthcare innovation can help deliver improved access to patients. We've had previous events in Cambridge and Liverpool with similar system leaders. And I know that this evening we're going to have a great conversation on Scotland's healthcare innovation vision and mission. 24 hours on from the First Minister setting out her programme for government, there's no better time to be examining how life sciences and innovation in general can collaborate to meet the very challenging environment for the NHS in Scotland. The lingering impacts of COVID-19, capacity constraints, as well as budget and workforce challenges, mean that tonight's discussion is more pertinent than ever. We're going to discuss the potential and promise of innovation to help Scotland become a leading global science destination. We've had a mixture of questions from people in our audience come in, and we've put them into buckets for tonight. And we'll be taking questions from the floor from people who we've selected. So if I call out your name, you will have a mic run to you, and hopefully we've got runners for the mics. But we'll also be having questions from our audience who are joining us by webinar. So the first audience poll question, which we're going to repeat at the end, is: how confident are you that Scotland will continue to attract global life sciences investment, including clinical trials? So I want you to hold up your hands, and I'm going to ask in batches. So the first batch is, are you not at all confident? So can you put your hands up if you're not at all confident that we're going to continue to attract global science investment? One hand over there. If you're not very confident, will you hold up your hand? So we've got one hand, two hands for not, 3, 4. I feel like an auctioneer. Not very confident. Hold up your hands if you are somewhat confident that we will continue to attract global life sciences investment. Okay, I'm going to say on that, for the people sitting at the front, that the ayes have it for somewhat confident. And how many people are very confident that we're going to continue? Okay. So I would say overall, the level of confidence is more for continued investment. So that's a good place to start. So no pressure that perhaps we can convince people who are not at all confident to change their minds over this evening. So, is Charles Weller in the audience tonight? Charles Weller isn't in the audience tonight. That's awkward. Let's go to his question then. I'll read his question out. Charles is General Manager for NHS Research Scotland. And Charles's question, which I'm going to put to the Cabinet Secretary and to Tom Steele, is how can we best engage with NHS staff to promote innovation? So, Cabinet Secretary, would you like to take that question first?
Yeah, thanks, Angela, and thanks for the invitation. Here, thank you to all of you who are attending. I look forward to an engaging conversation. And obviously afterwards, I look forward to being able to catch up with as many of you as I possibly can. I can also thank the organisers for putting on today's event. It's going to be really worthwhile, I'm certain of that. In terms of the NHS, first let me be upfront. So I have been in this role for just over a year. I don't come from a clinical background. I don't come from having worked previously in the NHS, and that fresh pair of eyes actually can be somewhat helpful, I think. And in the year and a bit that I've been the Cabinet Secretary for Health, let me be upfront about the fact that I don't think we have fully grasped the opportunity that life sciences and innovation can unlock for us in terms of some of the immediate challenges, but actually some of the future challenges we know are coming down our way in terms of public health. We've done bits of it, we've done bits of it well, we've done some pilots well. Governments can often suffer from pilotitis, and the NHS can do that too. But the upscaling that we need and that is required is something that I'm really upfront about, that I want to unlock further, and that's why the conversation with industry is one of one of the really key partners alongside academia and the NHS is really critical and key. So we have some fellowships around innovation. I think that's going to help. But if I'm being really upfront and honest, the leadership has got to come from the top, from the government. It's got to come from our chief execs, from our chairs. It's got to come from our organisations like the CFSD, whose entire creation and purpose, of course, is to drive innovation in the health service. But ultimately, and I'll end on this because I know you're trying to keep us to time, really ultimately what we have to do is make sure that the health service buys into the vision of what we're trying to do. And if you talk about life sciences, some people will know what we're talking about, but not everyone gets what we're talking about. And we've got to buy people into the vision, because actually what industry, my view, what most in industry, what most in academia, and what most people in the NHS are trying to do actually is to a common aim around bettering people's health. And confronting those health challenges, not just now, but those future health challenges. So we'll do lots of things around the fellowships, we'll do lots of partnership with industry, but actually we've got to take the NHS with us on the journey, and the way we do that is by ensuring that they are bought into the vision, and that's a job for me to do, as well as leaders in the NHS like Tom and others too.
Thank you. Tom.
Yeah, I'm in a privileged position, I guess, because I chair the Scottish Ambulance Service and NHS board in Scotland, and I'm also one of the leaders in innovation. So I can see it from, as it were, both sides of the impact we have on patients, which is ultimately why we have to make innovation work. And I'll, through the night, I'll maybe give some examples of how we're doing that in Scottish Ambulance Service. But it just really agreeing with CABSEC, what's most important for people to be involved? Leadership, absolutely. Senior leadership, but leadership right through NHS. And then involvement of everyone, and empowerment. These three things, without these three things, we will not achieve. People need to be involved, not done to. I go out and about a lot in my job talking to frontline clinicians, and there is an appetite for change. They want to do it, but having the empowerment to do it, having the resources to do it, having the time to do it is often difficult. Therefore, it has to become something which we really get behind as a leadership, and both political leadership and operational leadership, right across the 14 territorial boards in NHS and the other patient-facing and support boards. So I think it's the involvement and empowerment, Angela, is so important.
Thank you for that. Could I ask, is Alexander Mullen in the audience tonight?
Come up with solutions to problems, for example, drug deaths. We take it to like our public bodies and say that we've potentially got solutions, but then we end up ricocheting around the houses because nobody actually wants to make a decision. So, we end up getting put down to civil servants. They see the idea, but if we could actually have some support and funding where perhaps for £750,000, £1 million, within a year we could actually potentially have a solution to Scotland's drugs death problem, for example. And I find it very frustrating that we have to chase support money for very important public health things. So I'm just wondering, how could we actually make that more seamless?
Thanks, Alexander. I'd like actually, Sue, perhaps you to pick up with that, with your role on the cross-party group. Some thoughts there. Humza, I don't know if you want to pick up on that, and then I'm going to come to Anna.
Thank you, Alexander, for that question. Yes, we know that the drug-related deaths in Scotland are a challenge, more than a challenge. It's a shame that we have a rate of drug-related deaths in Europe. We need to be creative and innovative in how we tackle this. I've hear time and time again from people seeking access to rehabilitation services and recovery services that there are many hoops for them to go through to even access the services that we have now. We have to be much more nimble. We have to make our decisions much more quickly, especially when there's evidence that something works. And although I'm not in a decision-making role in this, I'm there to apply pressure to my counterparts as the Shadow Minister for Drugs Policy, and the role of the opposition is to present some other alternatives and to maybe hasten and push the decision-making to help save lives a little bit quicker. And I think that's the role that an effective opposition plays. And I know that it's very important that we hear from all the good practice that's out there or that could be being used right now to save lives. It's very important that we're aware of that, and it's made more aware than perhaps being down at that civil service level. So I'm more than happy to listen and hear those.
Yeah, so look, it's a travesty if we lose out on technology that could be saving lives, end of. And if that is because people either, get frustrated with the hoops they need to jump through, the various interfaces they have to go through, and then they end up possibly taking their technology elsewhere, and we've lost out on that. But ultimately, the people that lose out are the people that lives you could have saved and your technology could have saved. So it's a real travesty. Me and Anna had a really good conversation, and I'm really pleased actually we've recruited Anna to the position of chief scientist for health. Getting somebody of her calibre shows just how important an agenda this is for us in government. Actually, we should have that one interface, and the Chief Scientist Office that could be that interface. Now, there's got to be a balance. I think there is an understanding that nobody, and I don't think you're suggesting that, look, we just give you £1 million or well, that would be nice actually, right enough, but we just give you money without, of course, appropriate checks, balances when it comes to public money. Everybody accepts that. But there should be one place that you go to. That one place should do all the due diligence that is necessary, come to government with a recommendation, and then we should just be able to get that done and dusted relatively quickly one way or the other. And so I definitely see the CSO's office as a really important interface in that respect. And potentially there's a role here for NES as well. So I'll take this one away. I wouldn't mind after this conversation maybe picking your brain and bending your ear about that particular technology and making sure you're directed in the right place, because I think if there is technology out there that could potentially help us to save lives in terms of the drugs death crisis, as I say, it would be a travesty. And public finances are tight, but in drugs death, there's a national mission. That money is put on the table and it's there to help. So I'll take that one away off table. But your general point about going to too many interfaces is one that we recognise. And
how confident are you that the vision for 2025 and the wider life sciences strategy for Scotland is achievable? So same as last time, the studio to hold up your hands. So if you're not at all confident that the vision for 2025 and the wider Scottish life sciences strategy is achievable, hold up your hands if you're not at all confident. Consistent? If you're not very confident. Okay, a few people there. And over here, thank you. If you are somewhat confident. And very confident. We have a room of optimists in here tonight, because the somewhat confident and very confident response to the vision for 2025 and the wider life sciences strategy for Scotland is achievable. One through. I'd now like to invite Karen Tate to come to the boom mic. Karen is Senior Director at our laboratory at Q2 Solutions. So Karen.
So with the heavy focus at the current time over NHS recovery, I do wonder whether we are missing an opportunity to have patients here in Scotland benefit from innovative treatments. So could you give me some perspective on how you see Scotland being able to encourage patient participation in clinical trials to help bring them better outcomes?
Sue, do you want to take that question?
Yes, I agree with Dame Anna there. Yes, our people that live in Scotland are very willing to get involved in clinical trials. I don't think anyone across the UK would turn down the opportunity to take part in a life-saving clinical trial for them or a family member. But we have to also consider the geography that our country has compared to perhaps south of the border. We have got a third of the landmass, and we've got a lot of the resources are concentrated in our big cities. So we have to, when we're talking about inequalities, and it has to be really key that we focus on giving everyone the opportunity to take part in a clinical trial, irrespective of where they live in Scotland. And I think that is something we need to also drive on. And to do that, we have to have more researchers. We have to have more people doing research in all of our 13 geographical health boards and even in our island communities, because that's the only way we'll get equality. So to get those research careers with the diverse geography that's needed to support our diverse population and to give everyone the equal chance, that's where there is the most difference. The area that's most affected by the difference in clinical research funding between Scotland and those south of the border. The CSO's budget for supporting clinical research careers was only 700,000 in 2021. And by comparison, the NIHR budget for careers was over 109 million, meaning that funding for clinical research careers in Scotland is just 0.64% of that in England. So until we get funding that allows us to have an equal footing, we are not going to be able to give equality and access to clinical research to save the lives that we need across Scotland.
Very comprehensive and data-informed answer there, Sue. Thank you for that. And certainly as an employer in Scotland, when we're recruiting, we sometimes struggle to find the right people with the right skills. So I think you made a really valid point there.
Angela, could I just
add
from a personal perspective the importance of this? In 1999, I was diagnosed with acute myeloid leukemia. And because I was relatively young at the time, I was invited to join a clinical trial. And kind of 20 years later, I'm here to tell the tale. So I'm a huge advocate and indeed the treatment which I took was similar to the one which is still being used today with slight modifications, obviously. But as someone who's now in a leadership position around innovation, let me assure you that I feel that very, very strongly.
Thank you, Tom. And I really like that, because I'd like to take that back to something that Dame Anna said, which is how can we embed clinical research in routine clinical practice? And, from a national perspective, how can we help healthcare professionals who, when they're having a conversation with a patient about a treatment, a medicine, a diagnostic, whatever, they should also routinely be saying, we're aware of this study. And how do they become aware of that? Do you have a portal, where people can go to find the studies? And, GPs and consultants should be saying, but we also know about this clinical trial. Would you like to become part of that? And that should be absolutely routine and embedded in clinical practice. And if Dame Anna mentioned SHARE, so perhaps Dame Anna will just try your mic out, if you can tell people how they can get involved in SHARE.
SHARE, based in Dundee, brings volunteers who say that any time they have any need to have a blood sample, whatever happens, there is a register, and you can then use the tissue, use the blood for research, but also search the database that exists in Dundee to enroll these volunteers in clinical trials. And as I said, there are 300,000 Scots there, but more can absolutely join. And I remember launch of SHARE in Greater Glasgow and Clyde Health Board, where Chief Executive and I, as representative of the university at that time, both joined online whilst everybody was watching, and we had to give our age, and I was wondering whether I should be truthful or a little not. So I think colleagues in Dundee work very hard. This is funded by CSO, so partially funded by CSO, and I think we really should have more, because that gives searchable database for inclusion in right trial for right patient at the right time.
Great, thank you. I'd just like to continue the conversation on skills. Can I ask, is Nathan Barnett in the room? Do you want to introduce yourself, Nathan?
Yeah, I'm Nathan Barnett from SOLSA, which is the Scottish University's Life Science Alliance. I'd like to thank IQVIA as well for inviting me to attend this evening. It's been a great event. My question to the panel is, how do we ensure that life sciences skills provision keeps pace with industry need in the future?
And who would you like to direct that question to? I'm going to give you the chairman's choice here.
Well, I would maybe the two politicians, actually.
Yeah? So, Humza, do you want to kick off?
Sure, that was nice of you, thanks. So it's a big part of our life sciences strategy. You'll see it, and I don't expect everyone to have read through the strategy, but workforce for the future is incredibly important for us. And what we are doing now is investing in the pipeline. So actually, it's not just part of the life science strategy. If you look at our national economic strategy, life science, of course, is a key part of that. And I think there's a few aspects to it. One is making sure the pipeline, so working with academia, working with universities, working with industry, and so on and so forth, understand what the future needs are. So we're doing that in terms of developing that pipeline. I'm not saying we've got it all right, and it's going to take some time. Of course it is. One is the domestic pipeline. And the second one, which I think we do pretty well in, but actually there's still more to do, is on the international recruitment. I think Scotland is a great place to work. We punch well above our weight when it comes to life sciences and our reputation globally. I know some people have some concerns, not looking at anybody in particular here, Sue, but some people have our concerns around some of the international offices that we have and the work that we do there. But life sciences are one of the key areas that we promote in these international offices. Whether that international, actually some of the domestic offices across the rest of the UK as well. So I think Scotland has the ability to attract more. Now, this will sound like it's straying into the politics, but genuinely isn't. Want to continue to have this conversation with the new Home Secretary around immigration rules, because I think there is some just simple around those immigration rules that could greatly help us in terms of the life sciences sector here, not just in Scotland. It would benefit actually those in England as well as the rest of the UK as well. So if we can maybe kind of have that conversation in where the shared outcome will be for the whole of the UK, potentially there might be some mileage in that. So I'm going to take that conversation forward with the new team, the Home Office, and hopefully get some movement on that front.
Thank you. Sue.
Yeah, I suppose I could sit here with maybe a separate hat on if it makes it a bit more confusing. I'm also the convener of the Education, Skills and Young People's Committee at the Parliament, so I've got a bit of two-hat wearing here. So I think in terms of what we're doing right now, in terms of that immediate assistance and support for the industry, is to make sure we've got the skills that are there. I think it's really important that we allow the businesses to work with our college leaders, to allow short, sharp, micro-credential courses to upskill people that may be having to transition from one career into another. We've got an evolving economy. We don't know what's about to happen. Businesses may be struggling in the next 12 months or so with cost of living. It's something that's very high on the agenda. So we need to be able to take those people that may find themselves in a situation that they could be entering into a new career and giving them the skills to do that. We also have to be mindful of those young people that have come out of school that have not had the hands-on training that would allow them to come into a laboratory situation and pick up that role, because their chemistry hasn't had that practical element. So the role that colleges and universities have to play right now in facilitating our young people and training people that are wanting to enter into the life science industry is critical. Entering into the politics of it, I have to. There are more working in the Brussels office at one point than there were working on our drug-related deaths in terms of civil servants. So we'll just park that one there.
Thank you, Sue. Dame Anna, and then we'll finish on that question. But I know you've got some ideas.
Right. So first of all, we're very proud of appointing first innovation fellows in the NHS who work with industry on innovative projects, and there is funding for another 9. These are colleagues across the spectrum of health professions, so clinicians, doctors, nurses, physiotherapists across. And there will be another 9, and we decided to go for slightly younger colleagues in training because we believe that we need to train future generations of NHS academia workers to understand how industry functions. And the bigger theme that we've been discussing across both Scotland and internationally is so-called porosity between NHS or any health system, academia and industry. And this is something that has existed for years in the United States, but it's new to us. And this would be embedding people in training across from NHS or clinical academia into industry and another way. And here, I think, would be wonderful to have industry funding for this type of schemes, because I think it creates an understanding that cannot be gained from any other way, embedding in the system with ability to come back to your job and to continue in a collaborative, cohesive, coordinated way with industry without being afraid that this is a different world.
Dame Anna, just on that one, can I ask how many people from the NHS are here tonight? Few hands. So what Dame Anna's just suggested, whereby you can step out of your NHS role, go and work with a local life sciences medtech company in Scotland, learn new skills, but equally from an employer perspective like Q Squared Solutions, we could have people working in the NHS. Is that something that appeals to the audience? Does anybody want to make a comment on that?
So I'm clinical director for SHIP, working with Anna. So I suppose the direct answer to that is I was appointed as an NRS Innovation Fellow probably about 5 years ago. I think the important piece is almost that chimeric function of understanding industry's requirements, as well as thinking about what the NHS requirements are and being able to upskill those individuals to do those things, giving, as Anna says, the security of going back into the NHS to amplify the importance of working with industry around the specifications and our needs, recognising actually that market validation as a customer into the NHS is one point, but acts as a bridgehead to worldwide markets, and that's where the value is. And I don't think, and we have got challenges we know about provisioning of medical staff into emergency departments, which is my clinical context, but there's real value in being able to actually provide solutions that are scalable to respond to our needs, and that's where innovation is required.
Right, okay, so I want to change the subject a little bit now. I'd like to invite Duncan Moore.
Yes, I'm Duncan Moore. I'm also chairman of the Scottish Life Science Association. I'm also a biomedical investor. My question really is, how do we put in systems whereby the NHS can become a risk-sharing partner in the development of products? It seems to me that Scotland has a very good service-based industry in life sciences. Companies like Craneware, Charles River Laboratories, obviously IQVIA and Q Squared Solutions are mainly service providers. But we have this valley of what we call the valley of death in product development, where you go from an idea in a university which looks like it might work. You have to generate that human clinical signal, and in America and in Scandinavia, you can usually enter into a risk-sharing partnership with the healthcare system so that you don't have to raise tens of millions of dollars to generate the first 20 or 30 patient human clinical signal. So if we want to be competitive in Scotland in the creation of companies which are developing products, not services, I think the NHS has to be much more involved. And how can that happen?
Okay, thank you, Duncan. So I'd like to put that question, if I may, first of all to Tom Steele, and then to Cabinet Secretary.
Yeah, thank you. Absolutely. What we want to do is exactly as you say. We already have some innovative partnerships with industry and working very closely with procurement colleagues in government, such that we can do exactly as you say, to share the early stages and benefit from the later stages. I'm well aware of that model, having worked in the IT industry for many, many years. And when you're innovating, there is risk for both sides. But if things go well, you want to get the benefits of that, and both parties want to get the benefits of that. We don't just want to prove a solution in isolation. I think that's maybe what you're suggesting, that we prove it in NHS, and then we go to tender, and then somebody else comes in and gets a solution that does 80% of what you've said at half the cost. That's not appropriate for industry, and neither is it appropriate for the clinicians and ultimately the patients who are involved in the trial. So that very much that is the direction we're heading in, and the fact that we now have a central approach to RD&I, research and development and innovation, with decision-making organisation, our board, which Anna and I chair at the centre, will start to enable that to come together in a way that we've never been able to do so before.
Cabinet Secretary?
You know, there's little for me to add from what Tom said. I mean, that central coordination point is going to be key. But look, it also involves a mindset shift from government. I accept that too, but also from our partners in the NHS. And what do I mean by that? That sharing risk, by its very definition, of course, is not risk-free, and we have to accept that there may well be some failure, often on that journey to getting some success. And that's not easy for government because, one, we deal with public money, and there's rightly scrutiny on that public money, and therefore it always has to be a kind of calculated risk. But we always have to be upfront about the fact that if we're going to share that risk, as I say, there could be failure on the road to that positive outcome. So that takes a bit of a mindset shift from government in NHS, and I accept that. I also would accept that in some regards we do that risk sharing in other parts of government or other bodies, such as Scottish Enterprise would be a classic example, where they'll make an investment after, of course, a lot of due diligence, and that investment sometimes, hopefully, and the majority of times, goes on to really reap great rewards. But there will be cases in point where that investment has gone in and it hasn't quite worked out the way that Scottish Enterprise and we have wanted it. So I think mindset shift, leadership from our perspective, and again, I hate to kind of keep stressing this point, but we've got to take people with us on the journey. So the NHS absolutely, and the role that Tom, Jan and others are playing, we've got to ensure that everybody understands what the benefits and the shared benefits could be for this public that we serve if we have that partnership, that triple helix approach that Dame Anna often talks about. If we get that right, and we share some of that risk, then the outcome for the public we serve, and frankly for the NHS, given the pressures it's going to be facing it is facing and will face over the decades to come, that prize is a great one and worth sharing that calculated risk with industry.
I'd like to bring in Chris.
I just want to bring a few of those different points together, because it strikes me there's a thread. If this whole process around innovation, my world is patient data. So I've worked in the NHS for 30, 40 years in and around data, most recently working directly with patients in that complicated space about how health data gets used. Now, this is not, you talk about a share example. Share is a fantastic example of what happens when you would you like to become more involved in clinical research? And 300,000 have signed up. It's remarkable. Let me ask the other question, which is what about the rest of the people in the population of Scotland? Because all those people at some point are going to have healthcare interventions, health data generated about them, real world data, as it's called. What happens when we want to use that data to drive research? Because more and more health data has been produced. I think there was a press release I spotted this morning that said 97% of the health data that's been generated isn't used for research. Now, if you were a business, an industry, with an asset of this, and you're only using that asset to drive value, improve things, you'd be out of business fairly quick. So the opportunity to use real-world health data is huge. So if we're looking at innovation, that's a massive space. Then you need to look at what has been tried in the past, and particularly what has failed. I'm from England. I've got a good few examples of some of these. The reason big data initiatives fail, whether it's big data linkage or researchers, when you can't use patient consent as the mechanism for using the data, real-world data. The reason those projects fail, by and large, are not technical. They're not data, they're not standards, they're not interoperability, they're not even people or skills. The reason they fail is lack of communication, engagement, and support of the people whose data we're using. Now, that's pretty fundamental in terms of the innovation space. We haven't addressed that in England. There are some bits of work going on, but I think in Scotland, you've got a really strong opportunity to take a proper lead on this, to drive Scotland as a supportive, innovative space where you've got patients, family, public behind you to do the right thing, rather than feeling as if you've got to look over your shoulder to see who's going to criticise you for using data and trying to be innovative. I think we've got to make that switch. There's a real opportunity here. The amount of investment we put into clinical research, into researchers, into academic groups, into innovation experts, compare that with the amount we put into patient voice communication experts to bring people, populations, friends, family with us. It's virtually nil. It probably is nil. So Use My Data, which I work with, is a patient movement, which was simply set up by groups of interested patients who wanted to reduce the difficulties in researchers getting access to data. Got the ethics, got the permissions, but they were still having to jump through hurdles. So 10 years ago, we started this going. The hurdles researchers had to jump through to get access to real-world data, health data, to do research, which could save people's lives. The hurdles were massive. If you look at it today, they're still massive. And what we've seen is a huge abundance of more data being collected, but we haven't cracked that point of research.
We only find it in research, whether in
academia or industry.
We haven't cracked that problem. How they can get access to
data without
intervention after intervention after intervention, box after box,
committee after committee, which is not what patients want. And what I do is talk to patients about those problems in groups such as this, in numbers such as this, to tell them what's going on. I suspect we don't have any patients in the room.
Do we have any patients? I mean, we're all patients at some point. Yeah, everyone.
So,
yeah.
As an example, we talk about the triumvirate. Didn't say triumvirate, did you? I've forgotten the word now. Triple helix, thank you. I would argue there's another part to that, which is people.
We have to embed those
as part of this. And to do that, you have to let the people, the population, the public, know what goes on with their data, get them more involved, get them more informed, and they become advocates rather than being seen as the problem. They are absolutely a solution. And if we continue to do innovation, data innovation, the way we've done it in the past, without involving patients and giving them a much more direct, involved, supported voice, then we'll achieve the same results. Do the same thing, get the same results. Now, that's not what I think the future for innovation, particularly with health data, is.
Chris, thanks for that. I'm really pleased that you brought out the power of real-world data. And we saw, real-world data and real-world evidence studies, which we do a huge amount of. Back in 2016, I set up a bunch of patient groups to better understand the power of real-world data and real-world data studies. And then COVID came along, and if we actually look at many of the studies during COVID, that was real-world data evidence gathering in practice. And suddenly, people understood the power of, their data in things like the ONS COVID infection surveillance program, and a huge opportunity. And we should have embedded that at the time. But also, if I may be brave enough just to give an example of, you use the words, Duncan, risk share. In England, we have the Cancer Drugs Fund, as I'm sure you all know. Now, that was brought in because there were challenges about the maturity of cancer drugs evidence, and particularly in small rare disease communities, where it takes much longer to gain that evidence. So NICE would say, look, it's promising, but the evidence isn't mature enough. So the Cancer Drug Fund was brought in to mitigate that risk on the health service. So for 2 years, real-world data had to be collected. And I'm not saying the Cancer Drug Fund is the answer to everything, but risk share is about risk share. And maybe, perhaps in Scotland, you can take a more, risk-sharing approach using the power of the data that you have to do real-world studies about the particular innovation, whatever it may be. So I'm going to move on now to the data part. I've got a question from Gary White. about how can public trust be built in the use of health data for research and innovation. And that's one of the very reasons Chris is here tonight. So Chris, I'd like to hear your view. And then I'm also going to put Cabinet Secretary, your vision for how that can happen, because I know that that's something you're very passionate about. Chris, and we've had a time check, so let's roll. No, it's not 1 minute, it's got 10. Got plenty of time.
So how do you build trust in the use of public data? Well, tell people what's going on for a start. If you want to keep it simple, say what you do and do what you say. If you're using data, say what it is you're doing. I'll give you a challenge individually. Go home and trying to figure out your health data. We're all registered with a GP. Trying to figure out where your health data may have been used. And then try and figure out if you could ever find out if that is the case or not. And the answer is you probably can't. Now that brings mistrust. It brings caution. It brings worry in people's eyes, and we have to address those sort of things. So some basic things we can do, which is tell people what happens with health data. Tell them the reality. That's what I do as a living now. As soon as you begin to get that information out there, they go out there and they tell their friends, and they go back to their local hospital, and they go back to national groups with that knowledge of how health data gets used to try and break down some of those barriers. Until we can clearly describe what happens with health data and what choices people have and indeed don't have, and what the protections are and the safeguards are, we'll never engender that level of trust. And particularly the next step, which is, what's the point? And I give you the COVID example. The amount of data that was used to respond to the COVID pandemic and the rate at which was used was groundbreaking. I have never seen anything like it in 40 years. Totally groundbreaking. So what caused that? Well, there was a clear need that people understood. There was a behavioural change within the NHS across the UK to drive the data sharing, to drive the reports. Those reports, those COVID reports, were on the news every night. They were on the briefings every night. People got it. They understood what was being done with the data and why, and what it was telling them, and what we learned from it, and how it was improving things. At the end of it, you could see the results, whether it was the development of the vaccine or other things. So the population bought into the data thing. They might not have seen it as data, but there's a clear need, how it was done, what the result was. Now, if we could encapsulate that for cardiovascular disease or cancer, which kills far more every year than we lost to COVID in total, we'd make a heck of a lot more improvements in the way we can use data to drive innovation, to drive improvements, in healthcare, to reduce inequalities and the rest of this. But it comes down to that fundamental bit of trust. One question then I'll finish with. Whose job is it to talk to people about what happens with their health data? Is it the government, the opposition? I'll do balancing there. Is it me? Is it the health professionals? It's a really tricky one because nobody really owns the problem. And until we got somebody that says, right, communications is my brief, I'm going to figure out how we can coordinate far better communications across the country, which includes involving patients in delivering those communications. Involve the charities. They've got lots of access to very interested patients. I think we need to take a really significant step forward and address that. Because as I said at the start, none of this is technically difficult. None of this is around data. We've got loads and loads of data. We've got fantastically capable academics, researchers, industry, innovators out there. What we don't have is that framework which provides patient and public support to allow us to do these things. Unless we get trust engendered, we never will. We have to start talking about it and involving people.
Humza.
Again, it's hard for me to follow on because I agree 100% with everything that Chris has said, but maybe a couple of points to expand upon. So, I mean, I never like kind of using this phrase, given the scale of the tragedy of COVID, but it presented an opportunity in relation to people's understanding or communication of public health messaging. And people are a lot more understanding of the importance of things like clinical research. If it wasn't for those wonderful individuals that came forward to be part of the clinical trials for our vaccines, we would not be in the position that we're in at the moment and able to have this conference where over 100 of us are sitting here and able to enjoy today's and tonight's proceedings. It just wouldn't have happened if it wasn't for that game change of the vaccine, and the vaccine would not have happened if we didn't have people stepping up. So I think there is a better understanding from the population and government and others as a whole of the importance of this agenda. And it would be to our detriment, to our folly, if we didn't capitalise on that, again, for the shared outcome of bettering people's public health. The second thing I think is we need to be really upfront And we should be quite proud, actually, of the ethical frameworks that exist and that are very much in place and the industry have bought into, that would hopefully, I would hope, would give people confidence about how their data is being used. Because there is a fear, of course there is. We live in a world where just the word data itself gives people fear about how that data is being used, whether it's in a health space or whether it's with your mobile phone or whether it's with your social media, etc., etc. So we've got to be really upfront, and we should be proud actually of the work we've done in Scotland. Collectively, I think all parties are bought into the good work we've done on the ethical frameworks. And this last point I wanted to make was that point that Chris touched upon, who should be communicating. So I think we all have a role to play, but the message is going to be far more effective if it comes from, if I dare say it, more Toms, people who've, can talk about their own experience, how their life has been improved, changed, bettered because of life sciences, because of innovation, because of being part of clinical trials, as opposed to government, who, lo and behold, surprise, surprise, people don't tend to trust governments all that much. I know, don't fall off your seat. So people don't, we've got to be upfront and acknowledge that. We've got a role to play for sure, but absolutely people like clinicians, like people who have benefited from life sciences, from clinical trials, from innovation, they should be at the front of that communication. But the underlying message is, and I'm sorry to sound like a broken record, we have to take people with us on this journey, otherwise we will get nowhere.
I think the message is very clear from both you and from Chris. I want to finish on the data question. Can I ask, is Caroline Parkinson in the room? Hi, Caroline.
Caroline Parkinson, Director of Creative at Edinburgh Futures Institute, one of the 5 data-driven innovation hubs in the City Region Deal. And my question, which seems to have been slightly answered, but maybe you can focus on the front end of the question and get past the hurdles. What future benefits do you envisage from harnessing the power of data and data-driven innovation in health and social care, given we can get over the hurdles you've previously mentioned? And what's the prize?
Caroline, who would you like to direct that to? I mean, Chris is pretty obvious.
Chris is pretty obvious, and I wonder if there's ideas in the innovation space, maybe from Tom potentially Tom, as well.
And just give you a 5-minute, okay?
Well, if you want to start with me, I think I probably said much of what I would say. I agree that taking people with us is absolutely the right thing to do. The thing you've got to figure out is how you do that. Because if you're a researcher, if you're in your group, it's really tough to figure out how you take patients with you. So what we try and do is give practical examples of how you do that. So I think that's really important. The opportunities of using health data, if 97% of health data is unused, are huge. Just think about it from that perspective. We know the answers are in there, we're just not using them most effectively. I'll pause there, let Tom.
Perhaps I'll just give you practical examples from the ambulance service. When you see an ambulance park over a motorway, or maybe in a retail, and you think they're doing nothing, they're actually there because at that time they're as close as they can be to the next incident. And that's not an accident. That's by analysing our data, which every incident is recorded back for many, many years. And we use that in a dynamic way because things change, population changes, the way people move around changes. So that's one practical example. Another more strategic example would be the endeavour to move much more care into the community and for urgent care in particular. And again, the ambulance data allows us to inform the different parts of the country of what they should be doing first. What's the main condition? Because when we analyse the data, it very clearly shows that in affluent areas, the presentation to 999 is very different to in the more deprived areas. And therefore, where should we prioritise our, not just the ambulance service, but the whole of NHS activity to better pick up that demand? So, I mean, these are 2 very practical examples within my organisation.
Thank you. And Anna, I think you're going to get the final word tonight.
Right. Thank
you. No pressure.
1 minute or less. I think agree with everything that's been said, but I see health data as gold for Scotland. And I think we need to mine the gold. And I think for innovation, what we heard from Chris, if we get it right, we managed to get it right for COVID. Why not for cancer, cardiovascular, metabolic diseases? These are next frontiers we need to win with data. And I think for AI, machine learning, algorithms for early cancer diagnostics, everybody in this room could contribute if we have safe and patient community supported access to data. So this is Scottish gold. That's the way I see it.
Chris.
I'll make it brief.
It's fine.
I really agree with that. Artificial intelligence is a good example which we could really begin to utilise all that data out there. I'll come back to my point. How do we take people with us? And I wrote down 3 things. I'll make it 4. Artificial intelligence, life science, pharma and industry. If I walked out up the road now and said to somebody, what do I mean by pharma? They'd probably say some guy ploughing a field planting potatoes. What do I mean by industry? It's that big factory down the road with smelt belching out, well, if it's in Yorkshire it is, not up here. What do you mean by life sciences? People generally wouldn't have a clue. And if you talk about artificial intelligence, it's robots and Will Smith and various sci-fi films. So those very simple concepts demonstrate what we need to do in terms of addressing that communications gap. And it isn't huge, but we need to really take care about how we explain things to people to allow us to take them along the way. If we can get those messages clear, then we can all begin to deliver consistent, clear messages that people understand. And when I talk to patients all the time about this, it's exactly what they want.
Okay, so I'm going to draw tonight's event to a close. But before I finally close and invite you to take those drinks, thank our superb panel for getting here tonight. And I, as the chair and funder of this, would really like to thank all of you for fulfilling your commitment, having signed up to being here tonight. So thank you to you, the audience from the panel. Thank you.